Welcome to the Explainer. Today, we're diving into something tiny, a microscopic organism that has this huge global impact. And what's really interesting is how our entire game plan for fighting it has been completely flipped on its head.
All right, let's just jump right in with a number that's, well, it's pretty staggering. Over 40%. I mean, think about that. More than 40% of the entire world's population is infected with something you've probably never even heard of. It's a bacterium called H. pylori.
So when you hear a number that big, it obviously brings up a pretty important question, right? We're talking about this super common infection that, get this, usually starts quietly when you're a kid. So what is this thing? And should you be concerned?
Okay, so first things first, let's get a handle on just how big of a deal this is. We're not talking about some rare exotic bug here. This is a really common infection, a widespread and kind of hidden global health problem.
The best way to think about H. pylori is like a really stubborn squatter. It's this type of bacteria that's figured out how to survive in, of all places, the super harsh, acidic world of your stomach. And once it sets up camp in there, it can live for years, even decades, and a lot of the time you'd have no idea it's even there.
So yeah, that global number is over 40%, but it really does vary depending on where you live. In some places, like in British Columbia, it's more like 20%, or about 1 in 5 people. But what's really wild is that for something so common, we still don't actually know exactly how it gets passed from one person to another.
All right, so it's common. So what? Why is this tiny bacterium such a big deal? Well, the problem isn't really the infection itself. The real worry is what can happen down the road, if you have it for a long time and it's just left to its own devices.
And this right here, this is why we care. It's called the chorea cascade, and it's basically the path from infection to something much more serious. See, a long-term infection can kick off this dangerous chain reaction. It starts with chronic inflammation, gastritis. But over years, the stomach lining can start to wear away. That's atrophy. Then things get weirder. The stomach cells can actually get replaced by cells that look like they belong in the intestine. That's called metaplasia. And from there, you can get precancerous cells, or dysplasia, which can, in some cases, lead to stomach cancer. It's also, by the way, a huge cause of those painful stomach ulcers.
Okay, that sounds pretty serious. So the next logical question is, should everyone just get tested for this? Well, surprisingly, the answer is no, not exactly.
See, doctors don't just test everybody. They're really strategic about it. They focus on key groups where finding and treating this bug can make the biggest difference and prevent those serious problems we just talked about. So we're looking at people who have ulcers, anyone with a personal or even a family history of stomach cancer, or people who have that nagging indigestion that just won't go away. So how do they even find this thing? Well, what's cool is that there are a few really good ways. Sure, the most accurate method is to take a tiny tissue sample, a biopsy, during a scope, but that's pretty invasive. The great news is we have these excellent, much easier options, like a stool test or a breath test. Now there's a catch, and it's a big one. For those tests to work properly, you absolutely have to stop taking any acid-reducing meds for a couple of weeks beforehand. That's super important for getting an accurate result. All right, so if we've got these easy ways to find it, why is it so hard to get rid of? What's the big eradication challenge?
Yeah, this is the really crucial part. This isn't one of those infections where you just take one pill and you're done. Not even close. We are up against a really tough opponent here, mainly because of growing antibiotic resistance. I mean, the bacteria are just getting smarter. Plus, the treatment has to be long enough, and let's be honest, the drug regimen is intense. It's complicated, and sometimes people feel better and stop taking the pills too soon, which just lets the strongest bacteria survive and come back.
But this whole challenge, this battle, has forced medicine to get smarter too. And that brings us to the modern treatment strategy. The rules of the game have totally changed, and we now have a much better way to fight back and win.
So you can pretty much forget anything you've heard about the old way of treating this. For a long time, the standard was something called triple therapy, 3 drugs. But because of resistance, it just doesn't cut it anymore. Today's gold standard is way more aggressive. It's a 4-drug eviction team that you take for a full 14 days.
And doctors basically have 2 main playbooks for this 4-drug team. They both attack the bacteria from different angles to overwhelm it. The first one is called bismuth quadruple therapy. It uses an acid reducer, bismuth, yep, that's the stuff in Pepto-Bismol, and 2 other antibiotics.
The other main option swaps out the bismuth and one of the antibiotics for two different ones, amoxicillin and clarithromycin. The idea is the same. Hit it hard from all sides.
Okay, but what if you have a penicillin allergy? This could be a problem, right? Because amoxicillin is a key player here. It's one of our absolute best weapons. H. pylori just hasn't developed much resistance to it. So a penicillin allergy sounds like it would really throw a wrench in the works. Or doesn't?
This is where it gets really interesting. It turns out there's a bit of a penicillin allergy myth. A lot of people, maybe around 10% of the population, think they're allergic. But when you actually bring them in and test them properly, it turns out that more than 90% of them aren't allergic at all. This is a total game changer because it means most of those people can take this super effective drug.
Okay, so you've made it. 2 weeks of intense 4-drug therapy, you're done. The squatter's been evicted, time to celebrate, right? Well, hold on, not so fast. There is one more absolutely critical step.
And this is a question that comes up all the time. After going through all that, do you really need to test again just to prove it's gone? Is it necessary?
Yes, a big, emphatic yes. Every single medical guideline agrees on this. Because the treatment can sometimes fail and the risks are so high, you have to confirm that it's actually gone. It's the only way to be sure.
And confirming it is pretty simple. You just wait at least 4 weeks after you finish the treatment, and then you do another one of those non-invasive tests, the breath test or the stool test. Now, what you don't want to do is use a blood test. That's because the antibodies can stick around in your blood for a long time, making it look like you still have the infection even when it's gone. But the best news? Once it's confirmed gone, getting reinfected is incredibly rare, like only a 1 or 2% chance per year.
So let's wrap this all up. The big takeaway here is that H. pylori is a major deal. It's a huge cause of stomach ulcers and cancer worldwide. But the rules for fighting it have completely changed. Our whole approach has evolved. With better testing, more powerful 4-drug treatments, and that crucial final step of confirming it's gone, we finally have a solid playbook to kick this stubborn squatter out for good.